Greetings, I'm the dentist. Welcome back to DENTAGENDA. This is Chapter 3, Pediatric Dentistry. In this tutorial, we will discuss injuries to primary and permanent teeth and how to manage them properly. These are the points included in this tutorial. Repeated trauma episodes are frequent in children. About 30 to 40% of 5-year-olds have experienced dental trauma at least once, most frequently at toddler stage due to the bone elasticity, and that is the time they start to stand and walk and explore the surroundings. A young child is often difficult to examine and treat due to lack of cooperation and because of fear. The situation is distressing for both the child and the parents. A child's maturity and ability to cope with the emergency situation, the time for shedding of the injured tooth, and the occlusion are all important factors that influence the treatment you're going to choose. Keep in mind that there is a close proximity between the apex of the root of the injured primary tooth and the underlying permanent tooth germ. Tooth malformation, impacted teeth, and eruption disturbances in the developing permanent dentition are some of the consequences that can occur following severe injuries to primary teeth and the surrounding alveolar bone. Note that dental trauma is much more common in boys compared to girls, and in the upper teeth more than the lower teeth, and in case of increased overjet more than 6 mm. Always handle the situation in a calm way and start by assuring the child and the parents, since they will most probably be distressed. Radiographs are mostly required and very important. Consider the effect of any proposed treatment upon the permanent successes. Note that splinting of primary incisors is exceedingly difficult and not indicated, so whenever in doubt, extract the primary tooth. Now let's discuss the traumatic injuries in primary dentition and how to manage them. Starting with concussion. It's an injury to tooth supporting structures without increased mobility or displacement of the tooth. No sulcular bleeding, but with pain to percussion. Sign and symptoms. The tooth is tender to touch or bite on. No displacement or disturbance of occlusion. More sensitive. No sulcular bleeding. Treatment. Reassurance, soft diet, normal brushing, painkillers if needed, and follow-ups for 1 year. Subluxation, abnormal mobility but no displacement, and the presence of sulcular bleeding. Sign and symptoms. The tooth is tender to touch or bite on. No displacement, more sensitive than the other teeth with the presence of sulcular bleeding. Treatment always start by reassuring the child and the parents. Then, see if the time is near to exfoliation or at risk of being inhaled or interfere with the occlusion. In these cases, extract the primary tooth. Soft diet, normal brushing, painkillers if needed. Probably a flexible splint for 1 to 2 weeks is recommended if the tooth is very tender. If the tooth becomes unvital, root canal treatment or extraction would be the option. And follow-ups for 1 year. Intrusive luxation. It is the most common injury in primary dentition. In intrusive luxation, the tooth is forced into the alveolus and usually locked without any mobility. Sign and symptoms. The tooth appears shortened, and in cases of severe intrusion, the tooth may appear to be even missing. There is bleeding from the gingival sulcus. Treatment. If the X-ray confirms that the tooth has been forced into the follicle of the underneath secondary tooth, extract the primary tooth immediately. Otherwise, leave the tooth and wait to see if spontaneous eruption will occur between 1 to 6 months. Unfortunately, pulpal necrosis often follows, indicated by darkening of the tooth and loss of response to vitality tests. In that case, it is necessary to either pulp treat or extract the tooth. But note that if the tooth has an open apex, it is more likely to remain vital. It is also wise to warn the parents about possible damage to the underlying permanent tooth. In rare cases, tooth may become ankylosed and fused to the surrounding bone, and in that case, it is required to be extracted. Extrusive luxation, or what is also called partial avulsion. It is the partial vertical displacement of the injured tooth from its socket into an incisal direction. Sign and symptoms. Tooth appears elongated or over-erupted, and there is bleeding from the gingival sulcus. Treatment. If the extrusion is minor, like less than 3 mm, gentle repositioning is indicated with a flexible splint for 1 to 2 weeks. In severe extrusive injuries, however, like more than 3 mm, extraction is indicated with spaced maintenance. Follow-ups until the time of exfoliation. Avulsion. It is the complete displacement of the tooth out of the socket. The periodontal ligament is severed and the alveolus may be fractured. Sign and symptoms. Empty socket, bleeding, and pain. Treatment. Replantation is not recommended in primary dentition due to the risk of damaging the underlying permanent successor. When a primary tooth is avulsed and the tooth was found, no treatment is indicated other than space maintenance. But if the tooth is not found, however, clinical and radiographic examinations can confirm that the tooth is not intruded into the soft tissues. A chest radiograph may be indicated if the child displays breathing difficulties to ensure that the tooth was not aspired. The subsequent avulsion site will need to be monitored for healing and potential space loss. Note that if the child has an active digit sucking habit in case of avulsed maxillary incisor, a potential for space loss in the upper region exists. In such cases, an appliance with an artificial tooth may be indicated to prevent space loss and for aesthetic concerns. Crown fracture. It is the fracture in the coronal tooth structure from the incisal portion. It may include enamel only or enamel and dentine, with or without pulpal exposure. Signs and symptoms. Sensitivity, irregular incisal itch, and it might be accompanied with soft tissue laceration. Treatment. In case of minimal fracture, you can smooth the edge only and leave it under observation. But in case of larger fractures, you can either restore the tooth with composite or root canal treatment if the pulp is involved. Or lastly, extract the tooth. Periodic follow-ups are recommended until the time of exfoliation. Root fracture. A fracture of the tooth that involves the dentine, cementum, and pulp. Root fractures may occur in any direction or orientation, and they are generally classified as vertical fractures, usually also involving the crown, or transverse, or often called horizontal root fractures that can occur on any level. Signs and symptoms. Pain, mobility, coronal displacement. Treatment. Provided it is not displaced and there is a little mobility, advise a soft diet and keep under review until the time of exfoliation. If the coronal fragment is displaced or mobile, extract it, but leave the apical portion as it will usually resorb, and its removal may cause harm to the underlying permanent tooth germ. Follow-ups are recommended until the time of exfoliation. Moving on to the sequelae of trauma in the primary dentition. Ankylosis. The tooth fuses to the surrounding bone due to the destruction of the periodontal ligaments. Extraction would be the treatment of choice to prevent displacement of the underlying secondary incisor. Upon examination, the tooth appear in a more inferior level compared to the adjacent teeth, and on percussion you will hear metallic sound. Discoloration. It varies depending on the stage after the injury. Gray-reddish discoloration in the early post-trauma period indicates that the pulp is still vital and the injury is reversible. But when the tooth becomes more gray later on, it indicates pulp necrosis. Yellowish discoloration indicates calcification of the pulp, and in that case, no treatment is required. Necrosis, or pulp death. In that case, root canal treatment or extraction would be the treatment options. Know that the effect of the injury on the tooth depends on the stage of development of the tooth and the type and severity of the injury. Trauma can cause hypomineralization, hypoplasia, dilaceration, severe malformations, and arrest of development. Note that if the root development is complete, loss of vitality is a common sequelae following luxation, approximately in 70% of the cases, leading to inflammatory resorption of the root. On the other hand, teeth with immature apices have a much better chance of pulp survival. External or internal resorption of the root and pulp canal obliteration may also occur, therefore keep under review. Now to the traumatic injuries in permanent teeth. Injuries to permanent teeth are the same as mentioned in primary dentition. The management is what may differ in certain situations, as in avulsion. Avulsion in permanent teeth. The prognosis for avulsed permanent teeth is very much dependent on the actions taken at the place of accident. Treatment choices and prognosis for the avulsed tooth are largely depending on the vitality of the periodontal ligament and the maturity of the root. It should be reimplanted, of course, during the golden time, which is within 30 minutes since avulsion, as the PDL cells rarely survive more than 60 minutes extraorally, and the tooth should have been kept during that time in either saliva, saline, milk, or Hank's balanced storage medium, or even kept in the patient's mouth under the tongue or beside the cheeks, only if the patient is conscious and old enough not to swallow the tooth. But avoid storage in water or air dry, since both tap water and air dry storage rapidly damage the PDL cells. In case the tooth with the PDL tissues remain around the root, the tooth should be held by its crown. If falling on the floor, rinse under cold running water or shake it in saline for maximally 10 seconds. Place the tooth in its socket using digital pressure. If it doesn't readily seat, get the patient to bite on a gauze for 15 to 20 minutes. Compress the buccal and lingual alveolar blades with your fingers. Fixation using flexible splint for 7 to 10 days is recommended, up to maximally 2 weeks, as prolonged splinting may promote ankylosis. Fix the splint to the avulsed tooth and adjacent teeth after etching the enamel surface, and use temporary filling material, as it is less traumatic to be removed later on than composite. For teeth that have been avulsed and the extraoral dry time is greater than 60 minutes, the recommendation is a flexible splint for up to 4 weeks. And if you wonder why not longer or why not using rigid fixation, the answer would be that studies have shown that periodontal and pulpal healing is promoted if the replanted tooth is given a chance for slight motion and the splinting time is not too long. Pulp breakdown products into the PDL will contribute to the development of inflammatory resorption to the root surface. Although revascularization is possible in teeth with open apex, which is replaced within 30 minutes, those teeth with closed apices and longer extraalveolar time should be considered non-vital already. Intermediate treatment after splinting 7 to 10 days later. Review splinting. Remove it if the tooth appears firm and continue for further week if it's still mobile. If still mobile after 2 weeks later, check nothing has been overlooked like root fracture or loss of vitality. In these cases, prognosis is poor. If apex is closed or the tooth has an open apex but extraalveolar period more than 30 minutes, root canal treatment is the treatment of choice, with an initial intracanal dressing of calcium hydroxide or a plug of mineral trioxide aggregate or MTA, as it is the gold standard now. Don't wait for a radiographic evidence, since it is considered too late. Considerations after the reimplantation of the avulsed tooth. The splint should be placed on the buccal or labial surface to enable lingual access for endodontic procedure and to avoid occlusal interference. Administer local anesthesia upon replantation. Remove the coagulum from the socket with a stream of saline and examine the alveolar socket very well. If there is any fracture of the walls, reposition it with a suitable instrument. Replant the tooth slowly using slight digital pressure, and if not seated readily, ask the patient to bite on a gauze for up to 20 minutes. Suture the surrounding gingival lacerations if existed, and verify the normal position of the replanted tooth clinically and radiographically. Stabilize the tooth for up to 4 weeks using flexible splint. Administer systemic antibiotics and check for tetanus protection in case the tooth was polluted. Give the patient instructions to avoid participating in any contact sports and to be on a soft diet for up to 2 weeks, and to brush the teeth with a soft toothbrush after each meal and to use chlorhexidine mouth rinse twice a day for 1 week. Now let's discuss crown fractures. Infarction or crack. If the tooth sustains a marked crack in the enamel without loss of tooth structure, then placing a resin sealant over the infarction line may be indicated to avoid obvious staining of the line later on. In many cases, no treatment is indicated. However, the tooth should be monitored for signs of pulpal necrosis. Enamel only, or what's also called uncomplicated crown fracture. If the fracture is contained within the enamel surface only, it doesn't require immediate attention unless there is a sharp edge causing soft tissue injury. Upon examination, it is usually not tender. If tenderness is observed, evaluate the tooth for possible luxation or root fracture. Sensitivity pulp test is usually positive. Management. If the tooth fragment is still available, and preferably kept in water not to dry out and turn choky white, it can be rebonded to the tooth. Tooth fracture area can be smoothed with a dental handpiece and polishing burr, or left untreated if the fracture side is smooth to touch. Aesthetic concerns. The most conservative building up method would be to use composite resin with a perfectly matching shade or shades to build up the shipped part. Also, veneers might be an option, but in that case, Covering the adjacent tooth or teeth might be necessary. Enamel and dentine uncomplicated crown fracture. If the fracture of the tooth is contained within the enamel and dentine layers without exposing the pulpal tissues, this injury is classified as an uncomplicated fracture of enamel and dentine. Percussion test. Not tender. If tenderness is observed, evaluate the tooth for possible luxation or root fracture. Sensitivity pulp test usually positive. Also, sensitivity associated with exposure to air, food, or beverages. Management. If the exposed dentine is within 0.5 mm of the pulp, which will appear pink with no bleeding, protect the exposed dentine, preferably with a hard-setting calcium hydroxide cement and glass ionomer or composite on top. If time permits, this can be done with a crown former to restore the tooth contour perfectly. And keep under review. Again, also veneers might be an option, but in that case, covering the adjacent tooth or teeth might be necessary in some cases. Crown fracture with exposed pulp. The fracture involving enamel and dentine and pulp exposure. This injury is classified as complicated fracture. Crown fractures with exposed pulp are frequently sensitive and introduce an increased risk of infection because the pulp tissue is exposed to the oral flora. In severe fractures, the root may be involved, creating a crown root fracture, as we will discuss shortly. Treatment depends upon size of exposure, state of the root, time since injury, and the presence of other injuries like root fracture. If apex is open and there is an increased blood supply to the pulp, the likelihood of bulb death decreases, which is great, as the treatment should be directed towards retaining the vitality of the root pulp to allow root closure to continue. Management. If the pulp is non-vital, the root canal treatment is the best treatment option. Otherwise, treatment alternatives in case of vital pulps include one of the two options. Number 1, pulp capping. It is indicated if the exposure is less than 1 mm for less than 24 hours of exposure, whether in case of complete or incomplete root development, since the pulp is still vital. Cover the exposure with calcium hydroxide and place a restoration on top, whether composite or other restoration. Review the vitality frequently. The other option would be partial pulpotomy, and it is indicated if the exposure extends more than 1 mm for more than 24 hours of exposure, whether in case of complete or incomplete root development since the pulp is still vital, and in case of partial pulpotomy, the tooth should be restored with crown. Root fractures. Root fractures account for less than 10% of injuries to permanent dentition. When root fracture is suspected, it is advisable that 2 X-ray views at different angulations should be performed to improve chances of visualizing the fracture line. The prognosis for this type of injury depends upon whether the fracture line communicates with the gingival crevice or not. Actual treatment depends on the fracture position, and the prognosis is also affected by the degree of dislocation of the apical and coronal fragments and mobility or displacement. Root fractures could be classified into horizontal root fractures at the apical, middle, or coronal thirds, oblique root fractures, and vertical root fractures, and we will discuss each one in details. Apical root fracture. or horizontal root fracture at the apical third. Usually, no treatment is required unless mobility increased significantly. However, the tooth should be kept under observation as death of the coronal two-thirds of the pulp may occur. In that case, root canal treatment should be performed, and you only need to prepare the canal to the fracture line level, as the apical third usually retains vitality. But if you can reach full length, that would be perfect. Prognosis is usually good. If extraction is required, apical third can be left in situ to preserve the bone surrounding it. Middle root fracture or horizontal root fracture at the middle third. In the majority of cases, causes the tooth to loosen. Therefore, splinting is advisable to attempt to achieve hard tissue union of the fracture line using a flexible splint for 4 weeks. If coronal part is not displaced, loss of vitality is unlikely, but where coronal fragment is displaced, treatment approach would be repositioning, splinting, and if loss of vitality occurs, root canal treatment to fracture line level is sufficient as the apical part remains its vitality, but if you could reach full length, that would be perfect. Calcium hydroxide should be used as an internal dressing to limit inflammation and resorption. Delay in the treatment decreases the prognosis. If extraction is required, consider leaving the apical portion in situ to preserve the bone, noting that it most probably will remain vital. Coronal root fracture or horizontal root fracture at the coronal third. In this case, there is a high risk of direct communication with the gingival crevice, allowing the ingress of bacteria into the pulp. Where there is no obvious risk, flexible splinting up to 4 months is advocated to allow the union of the two parts with hard tissue of the tooth. Where the fracture line extends coronally, emergency treatment would be either temporary stabilization or extraction of the coronal fragment. Definitive treatment would be extraction of the two parts of the tooth, or preferably removal of the coronal fragment only, and an appropriate root canal treatment is done to the remaining parts, followed by dressing that will prevent the gingival tissues to overgrow on the root surface. You can use a temporary post-retained crown. Also, repositioning of the coronal fragment using adentine bonding agent and composite has been described. Permanent treatment would be post and core retained crown after root canal treatment. If fracture extends below the alveolar crest, improved access for crown fabrication is needed, so 2 alternatives would be either an orthodontic extrusion. When sufficient extrusion has been achieved, retain up to 3 to 6 months before fabricating a permanent restoration. Or the other option would be crown lengthening procedure. Oblique root fracture that doesn't extend above the alveolar crest can be treated as coronal fracture. Otherwise, consider extraction of the coronal portion only, leaving apical portion in situ to preserve the bone. Vertical root fracture. It is a longitudinally oriented fracture of the root, extending from the root canal to the periodontium. Vertical root fracture is one of the most common causes of extraction because the extraction is often the only treatment option. Most common causes for vertical root fracture include: number 1, wedging forces or pressure transmitted to the root canal surface during root canal obturation. Number 2, cyclic occlusal forces over the uncovered teeth after root canal treatment. And number 3, wedging and overexpansion for the post placement. Symptoms of vertical fracture can vary, making this a very difficult condition to diagnose. However, the signs that you may encounter would be mild pain when biting, the appearance of a crack when examining with a special dye under transillumination, a draining sinus tract appearing next to the tooth that looks like a boil or ulcer, which is often a sign that there is an infection beneath the tooth, a pocket between the gum and the tooth near the fracture line where the gum essentially detaches from the tooth. Also, a J-shaped radiolucency around the affected root can be observed in the radiographs. Crown root fractures. Crown root fracture is a fracture that involves enamel, dentine, and cementum. Crown fracture extending below the gingival margin, with the tooth is tender upon percussion test. Coronal fragment is mobile. Sensitivity pulp test is usually positive, and the apical extension of the fracture is usually not visible. Radiographs. Periapical and occlusal exposures are recommended in order to detect the fracture lines in the root. Treatment options for crown root fracture include emergency and alternative treatments. Emergency treatment would be temporary stabilization until a definitive treatment plan is made, like root canal treatment when the pulp is exposed. Then it is followed by the non-emergency treatment alternatives, which include 4 options. Number 1. Fragment removal only. It is the removal of the coronal crown root fragment and subsequent restoration of the apical fragment exposed above the gingival level is performed. Number 2. Removal of the coronal crown root segment with subsequent endodontic treatment and restoration with a post-retained crown. This procedure is preceded by either gingivectomy or osteotomy and osteoplasty. Number 3. Removal of the coronal segment with subsequent orthodontic or surgical extrusion to reposition the remaining root with sufficient length after extrusion to support the post-retained crown. And number 4. Extraction with immediate or delayed implant retained crown restoration or a conventional bridge. Last but not least, dental splints. Dental splints are used to stabilize a loosened tooth and to allow periodontal healing and improve patient comfort. In order to promote fibrous rather than bony healing that can lead to ankylosis, a short splinting time with a flexible splint is recommended. Prolonged splinting time and using a firm splint will promote ankylosis. For example, in case of avulsion, a splinting with a flexible splint for 7 to 10 days is recommended. In case of luxation, flexible splint for less than 3 weeks is advised. And in case of middle third root fracture, the flexible splinting time is extended up to 4 weeks. To stabilize a cervical third root fracture and encourage healing with calcified tooth tissue, flexible splinting is extended up to 4 months. There is almost an infinite variety of dental splints and too many different methods to fabricate them, but the following are the most popular. There are 2 main categories, the direct and the indirect dental splints. Starting with the direct dental splints that can be fabricated onto the patient's mouth. Number 1. The acid etch splint with composite or acrylic resin and wire. Number 2. Orthodontic attachments and sectional arch wire. Number 3. Ribboned which is the reinforced fibers. Number 4, performed metal titanium trauma splint. And number 5, using a sling suture to support the adjacent teeth together. The other category is the indirect dental splints. This type of splint is removable, which can cause trauma with insertion and removal, and therefore it is less preferable. It does, however, allow an assessment of the mobility or firmness of the teeth, which may be of a value in cases of reimplantation. The most common type is the vacuum-formed thermoplastic polyvinyl acetate polyethylene, or the Essex type, but this approach requires an impression of the traumatized mouth and involves some delay for a few hours or even days before the splint can be fitted, and that's why in practice the direct splints are preferred. Factors affecting the choice of the splint. Number 1. The type of the injury and therefore the splinting time required. For example, coronal third root fracture will need up to 4 months of splinting to allow the union of the two parts with calcified tooth hard tissue, and therefore composite and wire splint is advisable. On the other hand, replanted tooth prolonged splinting should be avoided, as it may lead to ankylosis. Number 2. The number of teeth injured and availability of uninjured adjacent teeth. For example, if both adjacent teeth are traumatized and no adjacent sound teeth are available, a full coverage acrylic splint or sling suture may be indicated. Also, the availability of facilities and time play a major role in your decision. And there you have all the points checked. Thank you for watching. Don't forget to subscribe. I'd like to have you here for more videos. And follow us on Instagram at DENTAGENDA for extra tips and tricks.